Welcome, everyone, to the Friends of NPACE podcast. I am Terri Schmitt, the Executive Director here at NPACE, and of course, as you know, a practicing family nurse practitioner. And as usual, I have a fantastic guest with us today, and I'm super excited to introduce her and to talk about the topic we're going to talk about. So with us today is Wendy Vogel. Wendy is an oncology nurse practitioner from Kingsport, Tennessee. We were just talking about the fact that she's probably going to get a little snow. It's cold there right now. But you got your bachelor's in science from nursing at Tennessee Technology University, and your master's of science in nursing in the family nurse practitioner program at East Tennessee State University. You are board certified, advanced oncology certified nurse practitioner, and a certified family nurse practitioner. And you are the executive director and a founding board member of APSHO, which is the Advanced Practitioner Society for Hematology and Oncology. You're also the associate editor of JADPro, and you've published in several professional journals. But no, you received the ONS Mary Nowotny Excellence in Cancer Nursing Education Award, as well as the American Journal of Nursing Book of the Year Award for the Advanced Oncology Nursing Certification Review and Resource Manual. And it's an instructor's resource also, right?
Mm-hmm.
Did I get all that
you
right?
Got it. You got it.
Okay.
I sound tired. That makes me tired.
No, it's so impressive. You've done so much. I feel so small.
Oh, please.
I am excited because we've gotten to work with you a little bit. So, Wendy, welcome to the podcast.
Thank you so much, Terri. I'm excited to be here.
We're so excited to have you, and I hope you're staying warm.
You too. Woo.
I know.
I'm definitely a warm weather girl. Give me warm weather any day over snow.
I completely agree. And I'm excited. We're going to talk about why I've gotten to work with you in the last few months and gotten to know you. But that's really brought to light your work with APSHO. So in season 2, we're going to talk about APSHO here in a minute and how that came to be. But I'm asking all of our guests how you came into the healthcare profession. How did you become a nurse?
That's a great one, because I think I just fell into it. It was because I hadn't tried that major yet. I've been to several different schools and tried a few different majors. I wasn't one of those little girls who dreamed about being a nurse, but I was interested in people and caring for people, and ended up in nursing school at Tennessee Tech. And I absolutely hated nursing school, but I knew that real nursing wasn't going to be like school. I hoped anyway. And so graduated, loved nursing as I began practicing, and practiced as an RN for about 10 years, mainly in oncology. Then I went back to graduate school, thought for about 30 seconds that I might want to be in pediatrics, but then I was so sick, my quarter of pediatric rotation, you get everything the kids have, that I stuck with oncology. And so I have been in oncology most of my career, and now as a nurse practitioner.
I love that. How did you start in oncology? Was it just like the first place, like all of us do med surg, and you thought, well, gosh, I'm going to do?
So I fell into that too. I've been so blessed in my life to fall into a lot of things. And so I was in home health, actually. I was working in a home health agency, which was really cool. Great stories from home health. If you've ever done that in family practice, oh my goodness. So interesting. But I was there and they said, we might want to do chemo in the home. Why don't you go take this course at Vanderbilt and see if we can do chemotherapy in the home, which never really panned out for obvious reasons, but it fascinated me. Oncology just became a passion. And so then my next job was working in an oncology practice and giving chemotherapy in that practice in a day when you did not mix the drugs under a hood, that you just kind of breathed in the toxic air as you did that. That ages me right there, Terri.
I was just going to say, you are dating yourself. I remember that when I say to people, like, the pharmacy didn't mix our IV. I was a NICU nurse for years. We did that. Like, we mixed those bags, we hung them.
Yes.
But also,
for chemo,
when people are like, we didn't use drip rates, I'm like, well, We actually did back in
We
the day.
did. We had to.
There weren't IV pumps everywhere. So.
We actually used little venting pins. So you would stick it in the vial. It had like a sharp pointy thing, and you stick
Yes.
it in the vial, and then it had a little apparatus where you attached your syringe to it. And then supposedly all the aerosols would go through that venting pin. So it was interesting. But regardless, oncology just became my passion. I started teaching other people about oncology within the practice that was associated with the hospital, and
Mm-hmm.
just kind of went on from there.
I love that. And then, dun dun dun, this is a great segue because I want to really talk about how App Show happened. What was the premise for it? What does App Show do? And how you were a founding member.
Oh, that's my favorite topic in the whole world. I think you could say I live and breathe and dream and sleep and everything App Show. So App Show is the Advanced Practitioner Society for Hematology and Oncology. It's the only professional society dedicated to advanced practitioners in hematology oncology. And so what we mean by APs or advanced practitioners, we include not only nurse practitioners and physician assistants, we also include clinical nurse specialists and pharmacists as well.
Very
So
nice.
AppShow actually began in 2014, and we celebrated our 10th birthday in November at our annual conference. And our annual conference is Jab Pro Live, and it's held all over, different places every year. So I was really fortunate to be one of the founding board members. I started out with the Jab Pro Journal, which was published by Harborside Press at that time, and became one of the associate editors there. And from that, it was such a success. People were dying for information about hematology oncology that was really specialized to advanced practitioners at that advanced practice level. So we worked with the journal, and it grew, and then it became a conference, JAPRA Live. And by that time, we saw what a great need there was for not just the conference, but now a professional society. We went from the second JAPRO Live, we made all of the attendees there charter members. So there was about 180 people. And we just hit 6,000 members in November of last year.
Congratulations.
Thank you. It just really speaks to the need that advanced practitioners have for information on oncology and hematology.
I
So
completely
the
agree.
App Show is just my love. It's my baby. I've nurtured it, and as a board member to board president, and then accepted the executive directorship 5 years ago. So that's
Well,
the story.
that was a good story. I agree. And I think sometimes, I've been a big supporter of the major national Nurse Practitioner Association. We're starting to work with PAs, and I met with a few of them this last week and their national organization. We've got to have these specialty organizations. There's too much to cover. It's too specialized to get support in a big organization or a national level the way that's needed. And oncology, gosh, is such a field with rapidly changing
Oh,
science.
my goodness, the number of drugs in the pipeline is incredible. More and more orals, which are going to really change the face of oncology treatment, more and more immunotherapy. It is an exciting field. You're on the cutting edge every day.
I love that so much. That's going to be so exciting. So, our audience has primarily been primary care providers, right? We're the first stop, most of us, most of the NPs here, although we have more and more acute care, and we can kind of speak
Mhm.
to that as well. I think sometimes I know as a clinical provider, there's this disconnect. Like the second someone gets a diagnosis, I send them to the oncologist and I don't look back. I'm like, I don't, it's like
Mhm.
dealing with a pregnant person. I don't know. Please call your OBGYN about your sniffles. I
That's the way
just,
I feel about hypertension and diabetes
well, so that's right. What we're
and
going to do is
back
so
pain.
important. So I guess, I guess my question in that is, what do primary care providers really need to consider? And why are you joining us for the March virtual? Like, I didn't even know where to go with that. A little bit about why
Well,
that's important.
I one of the reasons I'm passionate about working with you is I've always said in my practice that my best friend is going to be my pharmacist all the time, whoever my pharmacist I work with. But now, with all that we do to our patients in oncology and all the different treatments that we have, I think my best friend, colleague should be a family nurse practitioner or a
Mhm.
family nurse or a family, excuse me, physician assistant, because we've got to work together as a multidisciplinary team to take care of these patients now. If you think about it, 1 out of 4 persons in the US are going to be diagnosed with cancer. That means for every 4 people you see as a clinician, one of them is going to have a cancer. So you're either in primary care going to be trying to prevent it, you're going to be screening for it, you're going to be diagnosing it, you're going to be referring and collaborating with specialists, you're going to be monitoring for recurrence, you're going to be talking to family members about hereditary issues, you're going to be dealing with end of life and palliative care, and we've got to do that as a team. It's too much for just one specialty. And it's tough. I mean, it's easy to hand them off and say, this is a back pain, go to your orthopedic person. But in the meantime, you wouldn't send them off probably without some pain management or some symptomatic management. And I think that too, that primary care is so important because they're on the front end of this and they have a relationship with their patients and sometimes have to break that news to them. So understanding a little bit enough to say, hey, got you covered. Here's someone I'm going to send you to, and here's what I know about this. And I think it's just so important to be collaborative.
Yeah, I completely agree with that. I think I feel a huge deficit in screening patients otherwise who've already had cancer because we've gotten so good at treating some of them things that we used to, be devastating. And people survive and they're going
Mhm,
on. And, what happens, it's almost like prevention with a patient who's had open heart surgery. We still have to see them. How do you
mhm,
manage the rest of your life? And that we know is primary care, that changes for a person who's had a heart
mhm.
attack. The way I screen them, how aggressive I am, those things change. And I don't know how that changes for my oncology patients once they come back to me.
Well, that's a good point. And hopefully that when you're seeing that patient back after they finish their acute treatment, your colleague has sent you back with a survivorship care plan. And so I would ask for that because most places do complete those on patients, a survivorship care plan, which kind of tells the patient, okay, here's what to look for. Here's how we're going to screen you in the future, or you're going to be going back to your primary care for regular screening because we've cured you. So that's a really important thing to ask for from your colleague. Also, the NCCN guidelines, the National Comprehensive Cancer Network, is a fabulous resource for all of us.
Okay. I'm gonna
Um,
write that down.
it's free online. It's www.nccn.org. And if you go there, it's the latest and the greatest on how we treat cancer and some hematologic disorders in the US. And it's updated every 3 to 6 to at least yearly. It's updated. So it's great. Up to date is also another resource that many of us
Yeah.
have availability. But the NCCN guidelines is kind of like our Bible. I
Okay.
looked at it every day in clinical practice. And so there's a really important part there, 2 parts really for primary care, is if you suspect a cancer, how to diagnose it is the beginning part. And
Okay.
the other part is follow-up, which after they've gone through treatment, how should they be scanned? What kind of lab works do you need to perform and how often to do those? Probably most oncologists or oncology practices will be following them, those patients at least for 5 years, if not longer. But if they're not, for some reason, or the patient has left the oncology practice and prefers to be with their primary care providers, which happens, then you would want to know what I need to screen for.
Or insurance coverage changes.
Yes,
And they can no longer see
exactly.
that provider anymore.
Yes, exactly.
January 1st, I'm
Unfortunate.
getting so much of that right now. Yeah.
God.
Yep.
Mm,
Um, you said something else I want to build on. See, this is how we get tangential. I warned you.
mhm.
That's what happened. You mentioned how you're not comfortable managing something like hypertension, and so pulling someone else in. I'm actually seeing more of that I didn't see before in my family
Mm.
practices, that people who have a current oncology will still come to us and say, they're not going to touch this. I need you to manage this. Or the days I have chemo, XYZ is happening. Can you write orders for my rapid acting insulin? Should my blood sugar go up? Those kinds of things. So talk to me a little bit about that partnership. Are we pulling on
Mhm.
family practice more or?
I think what you're seeing is true. We are pulling on family practice more. But treatment now is not just your grandma's chemo anymore. The
Right.
range of side effects is huge, especially with immunotherapy, because we're hitting a lot of the itises, hypophysitis, hypothyroidism. We're hitting so many of those that we need help in managing those, even if we caused it in oncology. My practice early on was, well, if I caused it, I'm going to help fix it. I'd write the sliding scale insulin orders or whatever that may be, or I might try a antihypertensive agent, but if the first one doesn't work, I'm going to be reaching out for help. And different practices are different. I've worked with some oncologists who will say, no, I'm not touching anything that has to do with primary care. Send them back to their primary care provider, which can be an issue if they're access issue for a lot of patients where
Yes.
I live. I live in rural East Tennessee, and access can be a problem, especially for specialists. If I need to send them to an endocrinologist, really hard to get them in. And so primary care gets a lot of that. So I think you are seeing more. The range of side effects is huge. There's also a lot more drug-drug interactions than there used to be because we're giving more orals too. And there are some definite food drug interactions as well. Also, our oncology patients are showing up in the ED with things that may seem benign or, neutropenia, okay, but how bad is the neutropenia? Or they've got a fever and maybe nobody does a CBC in the ED and doesn't realize that not only does this patient have pneumonia, but they're severely neutropenic. So there's lots of things that could progress really, really rapidly to a fatal situation if you're not aware of what that patient's undergoing in their treatment.
Oh, this is so good. You're making all the family practice people out here nervous.
Oh, no, I
So,
don't mean to do that
no,
because
no, I think it's good. And you brought up things like the acute care and the E-Day. Like these people end up in the hospital for other things.
Mhm, mhm.
Someone's got to manage that or other life things if treatment is taking months and then they also develop XYZ during treatment, whether it's related or not, they'd be hospitalized for,
Mhm.
um, I bet
So
you get a
it's
little.
so that's why you need a best friend. You need a best friend who's an oncology AP, and I need a best friend who's a family practice AP, which I have one, and I love her. And we have referred patients back and forth. We've talked about the surgeons. I wouldn't send her here for her breast surgery, or where would you send her? We all got to have that.
You definitely have to have that. It's interesting that you spoke to rural patients. So I'm doing telehealth in multiple states, which is very interesting. Practicing to state in scope of practice and licensure, it just changes. But a lot of my patients are rural. Like they
Hmm.
may even have, or they're Medicaid or they're uninsured. And so they'll come
Hmm.
up on these things that we're concerned about, these devastating diagnosis or suspect of a devastating diagnosis. And man, trying to get in, right? If I'm going to
Hmm.
have to drive an hour and a half, 2 hours one way
Yeah.
for treatment, we're going to talk about that a little bit. So we started working with you because I don't know where to start. I don't know anything about oncology. So tell me a little bit about what you're excited about in the virtual conference we're going to do in March and maybe what you think primary care providers need to know that we're going to talk about.
I think we're going to touch some about drugs and drug interactions and side effects and things that are truly red flags that you need to know. Like if this patient is on X drug, oh my gosh, if they show up with this is what you should do. And maybe your normal treatments for what you would do are not what we would do because we know it's a toxicity of the drug.
Oh, gotcha.
So, making that colleague friend or somebody that you can phone a friend, if you will, is going to be really important. And one of the things that AppShow can do is help connect you with other APs who might be in your area that work in oncology or hematology.
Okay.
I'm excited too. About the toxicity part, there's also collaboration of care and how important that is in communicating between a social worker or a nutritionist or all of those pieces that are so important we know in primary care become even more so important in oncology care, but sometimes get lost by one or the other of us because we're focusing on the hypertension or we're focusing on the cancer and we forget that they might have trouble getting to the place for their treatment.
Mm.
So much of that is, it's huge. It's huge. And these drugs are so expensive, Terry. They are, especially the orals, they are, well, they're all expensive, but at least, you're getting it in an institution if it's intravenous. Not so, you're usually getting it from a specialty pharmacy. And so the financial impact on the patient is really vast. The other thing that I want to say before I forget it, in terms of the medication, is because we get our drugs from specialty pharmacies, you may not even know they're on it because it doesn't show up on their drug list, and their family pharmacist that they have doesn't know either.
Oh gosh, that makes an issue for drug-drug interactions. And patients can't remember all this stuff.
No, no,
It's
unfortunately.
We
We
struggle
have,
knowing that they're on metoprolol, even if that's the only thing
I
sometimes.
still can't say metoprolol very easily.
You'd be that patient.
But I can say, one of these cancer drugs a little bit easier than that one.
It's true. Okay. I appreciate that. The few things that and we needed you guys to like advise us where do we even start because what you just said were things I would not even consider. Because I'm sending that patient on, I'm letting oncology deal with everything, and then they're just coming back to get me. The things I was excited about that we're going to talk about are the cancer screenings that I didn't know I wasn't doing. Like, I'm really looking forward to that topic and genetic counseling in cancer
Mm.
that family practice should know about, not just sending someone like what we need to be considering in screening. How often will insurance even pay for that? But my all-time favorite topic we're going to talk about is when not to panic about a
Oh yeah,
CPC.
don't pan, because you get jaded, and I'm sure you do it in cardiology or something like that. Someone comes in and, we've sent them over there because they're a little bradycardic or something, and you're thinking like, they're on this drug that causes that, Wendy, don't worry about it, and we get referrals like their hemoglobin is, 9, or something, or their platelets are 200. They're not bleeding. They're, we're 100. We're good,
Oh
So
my
yeah, that'll be
gosh.
fun. That'll be fun. The genetics part is really interesting though too, because when I first began, I did some genetic counseling and genetic testing in my high risk cancer clinic, which I did, which we should talk about that too, because that's a really cool thing.
Okay.
Um, but it used to just be the BRCA genes, BRCA1,
Right.
BRCA2. That's all we did. And so if you grew up like I did in that era, and that's when you went to school, that's all you know. Well, my gosh, we are testing for just breast cancer probably over 80 different genetic mutations now. So if you don't know what you're ordering or you don't have a pal that works in genetics, you might have blown the only chance we have to get genetic testing because there are some limitations on how many times you can test. And so it's always best to send to an oncology professional or a genetics professional in that. There's not enough genetic counselors in the United States. We have a huge shortage of those. So we do have a lot of advanced practitioners who are functioning in those roles and becoming certified as a genetic specialist.
Are they in oncology practices? How do I find them?
Usually, yeah, usually in oncology practices
Okay.
or high risk clinics. So high risk clinics are really interesting too.
Oh,
So if you've
tell
got a
me that.
patient, so this is fun. This is fun. So this is what I did in for years. Um, started it when I was working in Bristol, did that for 10 years, came here in Kingsport and, completed, another 13, 15 years of that. So a high-risk clinic is for patients who don't have a diagnosis of cancer, but for whatever reason have a higher risk. So maybe they've got 6 family members with colorectal cancer, or maybe they know there's a genetic mutation in the family, but they're not really sure if it's a genetic mutation on the tumor or a genetic mutation actually in every cell of their body.
Gotcha.
So hereditary genetics versus somatic genetics.
Mm-hmm.
So understanding that is really important. So a high-risk clinic, I would see patients who might have a benign breast lesion that was atypical hyperplasia. Well, that puts them at a future risk of having a breast cancer.
Okay.
So those visits usually lasted an hour, hour and a half. I would do a full health history, looking at and do a risk assessment on them. I would do a physical exam on them, teach them how to do, for if it was a breast patient, a breast exam. We would talk about then prevention methods. We might talk about medication. So there's a drug called tamoxifen that we use to decrease the breast cancer risk. But again, that comes with side effects, problems, issues. You have to fully disclose to patients what they're getting into and what the risk benefit is for that. We also talk about screening. So if you've got a woman who's at increased risk for breast cancer, you're going to want to start screening earlier and do it more often. And so we may bring in things like mammography and MRI, so alternating those every 6 months. So they're getting screened every 6 months instead of yearly by mammography. So fascinating practice. I love that. I would do that one day a month in my practice.
Very nice.
Yeah.
Oh, I like that.
It's
How do
kind of
people
hard.
find high-risk clinics? Like,
So my referral sources came from surgeons who find these benign but higher risk lesions. They also came from primary care. They would come from the mammography centers. They would come from a lot primary care, though, in my practice. GYNs
Okay.
would do that as well. When the genetic testing that you can do at home came out, I get a lot of self-referrals too, because those things are not, you can't take them for gospel in terms of genetics. It might say you're at higher risk for breast cancer, but you really have to delve into that more with deeper genetic testing. You can't just take that. So just really fascinating. So I would ask your oncology practice first, and then your GYN practices may be aware of them as well. I was the only one in Tennessee for a long time that did the high-risk clinic, and now we have some in Knoxville and Nashville and probably other places as well.
Yeah, still an access issue for those rural people, but we're working on it. Interesting. I'm so excited about the virtual conference in March, and I'm thrilled that you guys are working with us. What are some, for our audience who can't make it to that, or maybe just podcast listeners, besides the NCCN guidelines, what parting knowledge should they just be considering for their practice? Just a pearl or two that they should take with them about either dealing with oncology patients while they're in the midst of it, or when they come back to them, or where we should just be continuing to get education for resources for primary care.
So words of wisdom, pearls, quick tips, NCCN guidelines, definitely great resource.
Okay.
I would also say oncology is not sad. Everybody says,
I love that.
You just must be such a special person. And like my Tennessee accent comes out, a special person to work in oncology. I'm like, no, really? I get more from my patients than they do me. It's not sad all the time. And you probably deal with as much sadness in your practice in primary care as I do in oncology. And we know people are going to die in oncology, but we also, when you're in the practice, you see people get well. You see people go away and never see you again. This is so cool. And when you're in acute care, like in the hospital, when you're exposed to it in nursing school or, PA school or whatever, you see the sickest of the sick. You don't see those success stories. And oncology patients are special. They're the least likely to sue you. for one, but also many times they have their priorities different. They're grateful for every day, they have a different outlook on life, and it is a privilege to serve those people.
Oh, I love that so much. That all started with oncology is not sad.
It's not sad.
It is. Oh, I would love to wrap it up that way. Oncology is not sad. Use
Okay.
the NCCN guidelines.
Mm-hmm.
Also, join us for the virtual conference if you can.
Yes.
And all of these acute care and primary care providers need a friend who's in oncology.
Mm-hmm.
We've got to have an oncology provider friend to help us with screening or things that are, because I know sometimes things come up in tests and I'm like, I don't know what that means, whether it's a radiologic or a blood test. And I'm like, what do I do next? Do I just
Mm-hmm.
send to oncology? Are there other screenings I should be doing? What the heck is this thing
Mm-hmm.
even? That's
Yes.
abnormal. All right. I'm gonna have to find an oncology friend. It might be you, Wendy.
Yes, and if you need a friend, come to APSHO,
Oh,
APSHO, APSHO.org. We'll welcome you with open arms. We're soon going to have a new to oncology AP course through our APSHO AP Academy.
oh,
So
I
if
love
you're
it.
interested in just getting, basic AP information about oncology, that's another good way. This conference is really going to meld primary care and oncology together. And it'll be a great start to a super collaboration.
Oh, thank you. I'm looking forward. I think we ought to do more stuff in the future. Yes, appshow.org. And you have continuing it there for people who
Mhm.
are new in the oncology field. I love that you emphasized that. But I hope we can get my fear with this conference was that we would write the word oncology and all of my acute care and primary care APPs would tune out. They would say, that
Mhm.
is not me. When it
Mhm.
absolutely
Mhm.
is. 1 in 4 of your patients is
That's
this.
exactly right. When I love to mentor students, and they always hate to come to the oncology thing, but my goal is if I can't make you at least a tad interested in oncology and intrigued, then I have failed. So, and I will say that 99% of my mentees come away saying, now I have a different perspective now.
Yeah, and it is a rapidly changing field, like year to year to year. Like
Mhm.
providers need to keep up as much as we keep up with hypertension guidelines and diabetes guidelines. We better know what's going on with patients in oncology because we
Totally
have them.
agree.
Oh, thank you so much for being here. I really
Thank you,
appreciate it.
Terry. Thank you.
Aw,
Have a good day.
I will. And for all of you listening, we're a big shout out to Wendy and to App Show, and we appreciate your work here. We're super excited to work with you and ACCC. For those of you who don't know, check out ACCC and what they offer providers and patients. Also, we're going to do a March virtual on the 12th and 13th. Thank you for being here. We're going to put this as soon as we run it. In the future, it'll be on Apple Podcasts, on Spotify, on our YouTube channel, and all things NPACE, you can find us there. We're an ANCC accredited provider, and we will also be applying for AAPA CME education for this particular conference, and then we'll have it on demand. Wendy, thank you so much for being here with us
Thank you,
today.
Terry.
All right, to everyone who tuned in, thank you. We'll talk to you later. Bye.